Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observation and commentary on the JCO article, Utility of Routine Post-Therapy Surveillance Scans in Diffuse Large B-Cell Lymphoma by Carrie Thompson et al. My name is Ann LaCase, and I am an Assistant Professor of Medicine at Dana-Farber Cancer Institute in Boston, USA. My oncologic specialty is lymphoma. The utility and optimal timing of post-remission imaging in patients with diffuse large B-cell lymphoma, DLBCL, the most common subtype of lymphoma in adults, has long been an issue of controversy. In recent years, as data has emerged in both the scientific literature and the lay press linking CT and PET-associated radiation with an increased risk of secondary malignancies, the debate is intensified. Physicians and patients alike have strong opinions, and the topic is frequently discussed during patients' office visits. No randomized studies comparing clinical follow-up only to periodic surveillance with CT scans have been performed. Moreover, although a subset of patients with recurrent DLBCL are cured with second-line therapy, detecting an asymptomatic relapse on imaging has not been shown to translate into improved survival. Thompson and colleagues examined the value of post-remission surveillance in patients with DLBCL enrolled in two prospective databases, one at the Molecular Epidemiology Resource of the University of Iowa Mayo Clinic Lymphoma Specialized Program of Research Excellence, and the other at the Léon Bérard Cancer Center in Lyon, France. Of 552 patients in the Iowa Mayo cohort, 104 patients experienced relapse. 67 patients presented with symptoms prior to scheduled follow-up. Of these, 63 had recurrent DLBCL and 4 relapsed with indolent lymphoma. Of the 37 patients in whom recurrence was detected at the time of a planned visit, 24 patients, 13 of whom had DLBCL, had clinical evidence of recurrence, symptoms, finding on physical exam, or elevated LDH. 9 of 13 asymptomatic patients whose relapses were detected solely by imaging had documented DLBCL. Overall, 9 of 522, or 1.6%, had disease detected solely by surveillance imaging. The findings in the Lyon cohort were similar. 55 patients had disease recurrence in 222 evaluable patients. 28 cases of DLBCL occurred in 34 patients presenting prior to scheduled visits, and 18 DLBCLs in 21 recurrences were detected on routine follow-up. Only 4 of 222, or 1.8%, patients relapsed with DLBCL found on imaging only. The overall survival of patients with relapsed DLBCL detected at the time of planned visits was not significantly different compared to that of patients who presented prior to scheduled follow-up. The vast majority of recurrences in both groups occurred in the first 2 years following the completion of initial therapy. In addition, a significant number of patients who experienced disease recurrence had equivocal findings on post-treatment PET scans. Although the patients were followed in the context of a prospective database, the frequency of patient visits and surveillance imaging was at the discretion of the treating physician. A sensitivity analysis was reported for 276 patients from the Iowa Mayo cohort. A median of 4 scans, 2 per year, were obtained in the first 2 years of post-treatment observation. The rates and timing of detection of recurrent DLBCL were consistent with those reported for the whole group. Given limitations of the database, for symptomatic patients who presented prior to scheduled follow-up, the proximity of the most recent visit or scans was not available. Importantly, results of surveillance imaging were very likely to have been known to the treating physician at the time of the visit and could have influenced the detection of symptoms or abnormalities on exam. The findings of this study are consistent with a number of prior reports in which post-remission imaging has not been associated with the early detection of recurrences or improvement in survival in patients with diffuse large B-cell lymphoma. A rigorously designed randomized study examining this question would be valuable and remove any biases generated by the nature of database studies. Eliminating surveillance scans could have a number of positive consequences at both the individual and societal level, including decreased patient anxiety, reduction in radiation-associated secondary malignancies, and substantial cost savings. The elimination of all post-remission imaging in the routine care of patients with DLBCL, however, might have unintended consequences for the conduct of clinical trials. The primary endpoint of many therapeutic trials in aggressive lymphoma is progression-free survival, which has been shown to correlate strongly with overall survival. Progression-free survival is determined by post-remission imaging at predetermined intervals. If scans are no longer covered by insurance, the cost of performing clinical trials, particularly in the cooperative group setting, might become unsustainable. None of the existing literature incorporates pretreatment prognostic indicators in the determination of surveillance strategies. Patients with the activated B-cell subtype of DLBCL on gene expression profiling have significantly worse prognosis with standard R-CHOP chemotherapy compared to those with the germinal center subtype. In addition, patients with lymphomas harboring gene rearrangements in MYC BCL2 or BCL6, so-called double-hit lymphoma, as well as those with overexpression of MYC and BCL2 protein, also experience high rates of disease recurrence and poor overall survival. Stratifying patients according to these prognostic indicators could identify subsets of patients who might benefit from routine post-treatment CT scans. Patients with aggressive disease, however, may be more likely to present between scans with symptomatic disease. Therefore, determining if early detection of recurrence translates into a survival advantage is critical. Novel techniques to detect tumor-specific DNA in plasma may eventually replace surveillance imaging and lead to earlier detection of relapse prior to the development of symptoms or radiographic abnormalities, resulting in cost savings and a reduction in radiation exposure for patients. Until these become available in routine clinical care, this study by Thompson and colleagues supports the judicious use of CT scans for patients clearly in remission at the end of initial therapy. The NCCN guidelines, established by expert panel weighing the risks and benefits, suggest CT scans every 6 months for the first 2 years after the completion of chemotherapy and thereafter only if clinically indicated. This is a reasonable strategy, though the risks and benefits of scans must be discussed with patients and individualized. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.